Across the country, prescription pain pills are killing Americans. Lawsuits against pharma companies that make the drugs are piling up, and leaders are desperately seeking solutions to combat the opioid crisis. Here at home, Providence Health is making changes to fight addiction that start in the doctor's office. Today, we'll hear from doctors and a patient about what's working. From KGW News, this is Straight Talk with Laural Porter.
Hello and welcome to Straight Talk. I'm Laural Porter. Oregon, like the rest of the country, is experiencing an opioid crisis. According to the Oregon Health Authority, an average of 5 Oregonians a week die from an opioid overdose. In 2012, 900,000 Oregonians received an opioid prescription. And even though prescription rates have gone down since then, we still have one of the highest rates of prescription opioid misuse in the nation. Providence Health has taken notice and says while it believes opioids are often necessary, it feels compelled to improve patient care strategies to address the opioid crisis. Here to tell us how they're doing that and how it's affecting patient care, welcome to my guest, Nancy Collins. She's a chronic pain patient with a history of opioid use. Dr. Shora Nemeth, a pain and palliative care specialist at Providence, and Dr. Jeremy Lynn, Medical Director for Emergency Services for Providence in Oregon. Welcome everyone to Straight Talk. It's so great to have you here to talk about this really important issue.
Thank you.
Thank you.
Thanks for having us.
Let's go around the table and please share with us, describe how you would describe the current opioid crisis in Oregon and how it's affecting Oregonians. We'll start with Dr. Nemeth.
Yeah, well, thanks for that question. It's a complicated answer and one that I don't know if we'll be able to delve too deeply into at the time that we have, but I would phrase it in the terms of, number one, intended consequences, and number two, unintended consequences. So the idea was that the prescribing of opioids had just run rampant. We really needed to find a different solution for pain. So there was a clampdown on prescribing of opioids, which means less people got opioid prescriptions, which means that more lives were saved. The unintended consequences for that were that people still felt the need for something, and so people turned to street solutions, whether it's synthetic fentanyl or heroin. So on one hand, we've cut down the prescription crisis, but we've also started another crisis of illicit substances. So I would describe it again as intended and then unintended consequences.
Hey, Dr.
Any
Lynn.
thoughts?
Yeah, no, I agree completely. Everybody knows somebody who's been impacted by the opioid crisis, whether they've been on pain medications themselves or they have a family member who's struggled. And unfortunately, many people know people who've overdosed on opioids. And so, like other parts of the country, we're seeing that exact same effect in Oregon. However, with the advent of some of these synthetic agents, we're unfortunately seeing some patients who don't even make it to the emergency department because they're so much more potent. And I think that's one of the major risks that we're seeing now.
We'll talk more about that a little bit later. Nancy Collins, from a patient point of view, how would you describe it?
Well, the intellectual side of me says that Oregon is in the midst of a major public health crisis. And 4 months ago, I attended a statewide conference in Bend, Oregon, and there were 450 representatives across the state, government, private, nonprofit agencies, public health and mental health providers, and I left there with the feeling of incredible hope that this problem is being effectively addressed. And I am aware that prescribing rates are down in Oregon.
Well, let's take a look at some of those factoids that Providence has provided us about opioid use. According to the Oregon Health Authority, and this is what you're referring to, Nancy, despite a greater than 30% reduction in opioid prescriptions in Oregon since 2012, prescribing rates across the state remain high. During 2017, more than 20% of all Oregonians received at least one opioid prescription. Long-term opioid use often begins with the treatment of acute pain. The Centers for Disease Control reports a strong connection between the duration of a first-time opioid prescription and long-term opioid use. Also, many patients who receive an opioid prescription do not use all of the medication, leaving pills and household medicine cabinets in reach of those at risk from misuse and abuse. Let's find out more about opioids. We talk a lot about it, but Dr. Nemeth, what exactly are they? What do they do?
Opioids we used to refer to as narcotics. We've kind of gone away from that in favor of the term opioids. A lot of people say opiates. Technically, opiate is morphine or heroin derivative. Or opioids refers to the larger category, fentanyl, methadone, things of that nature. So opioids are substances that act within our body in different places that essentially will dull our perception of pain. They have a number of side effects, as we've heard about nationally. Respiratory depression, if taken too much at once. Constipation is one of the other ones, and other things that go along with those. But they bind to the sites in the brain and the periphery, and they prevent us from feeling pain, and I would say acutely, which means in the moment. But we've discovered that they also have some downstream consequences. Long-term use of opioids activates the nervous system in a way that we didn't understand. So long-term use of opioids, because of the binding sites of these particular molecules, actually stimulates the nervous system, can perpetuate pain. So higher doses, longer-term use actually can cause pain. So it's a difficult conundrum because people who are on the medications feel as though they're the only thing that's holding them together. However, their nervous system is telling a different story. But when you have a conflict between what your conscious and your unconscious are telling you, then oftentimes the conscious wins.
Dr. Lynn, what are you seeing in the ER?
Yeah, so we see all sorts of patients come in with pain, some acute pain and some patients who've been on long-term pain medications, just like Dr. Nemeth just described. And this is a conversation I have with patients about how, although you feel like the pain medication is the only thing that makes the pain go away, the reality is one of the reasons why you're having such heightened experience of pain in the first place is because you've been on pain medications for so long. And it is a really, it's a sad irony that the desire to treat pain initially in some ways creates a more severe pain condition in the long run.
What are some of the other names for opioids? We hear Oxycontin. Are there other names?
Well, there's all sorts of brand names and different flavors, if you will. Oxycodone, Oxycontin, hydrocodone, Norco, Vicodin, fentanyl, of course, being one of the ones that's used in the hospital typically, but now we're finding synthetic derivatives from China, I believe, mostly on the streets.
Nancy, you have a chronic illness. Tell us a little bit about your illness and how you started using opioids.
Well, this is a story that dates back, frankly, 20 years. I was in severe pain for 2 months, and although I sought medical advice, no one knew what was wrong with me. And finally, on my 4th visit to the emergency room, I was paralyzed on the left side of my body and cognitively challenged, and I was admitted to the hospital and diagnosed with a very rare autoimmune and inflammatory disease called sarcoidosis, but specifically for me, neurosarcoidosis, because my lungs, my pulmonary functions returned to normal.
So did they prescribe opioids then to treat your pain?
They did not. In fact, I think, if I recall correctly, I think pretty much all my medications were taken away, although I had never really tried an opioid, except I did go to a pain management doctor who prescribed opioids. Boy, I took them when I was in agonizing pain, and they did absolutely nothing.
So did you become dependent on opioids at some point?
No, not at that point.
Okay, tell us when you did become
in the year
dependent.
2002. I began to experience excruciating pain. It was unpredictable. I didn't know when it would happen. I didn't know how long it would last. It could be 15 minutes, it could be 45. And then it would disappear, and then it might reoccur again, and it dramatically affected the quality of my life.
So let me ask you, at the peak of your illness, how many opioids were you taking?
Well, in the year 2006, I was, I think, and I was taking oxycodone and morphine. And I think I probably took initially 30 milligrams of morphine.
Let me turn to Dr. Demuth, because you ended up in the pain management clinic. Can you describe for us what was going on with Nancy and how she ended up in your clinic and how you helped her?
Well, Nancy did a lot of work to help herself, quite honestly. She had suffered with chronic pain for about 20 years, I think, by the time we had met. She'd been on chronic opioids, and I'd been working for a number of years to try and get this clinic functional and up and running within Providence. We had opened the clinic in the primary care center within Providence, and we're looking for patients. So her primary care had suggested that she come see us, and she was one of our first patients.
We have some video of your appointment with Dr. Demuth earlier this week. We're going to show some of that video. And Dr. Demuth, will you tell us some of the therapies you're using? How are you helping patients reduce their dependence on opioids?
Yeah. So we have a lot of things available within the clinic. I say that we offer the full spectrum of pain techniques that any standard clinic would offer. But on top of that, I also have, for instance, a naturopathic physician. I have a yoga instructor, I have a social worker, I have a peer support specialist. I'm probably forgetting somebody that I'll get in trouble for not mentioning, but we have a whole team of people. The idea, Laurel, is that treatment of pain is not something that can be done by a physician, and the literature would bear this out. Treatment of pain needs to be done in a multidisciplinary manner. We need to be able to educate people. We need to be able to show them through demonstration that movement, even though it hurts, it's not damaging. It's okay to move. They need to be coached, and we also need to influence lifestyle changes that are continuous and not just a point solution. Oftentimes clinics focus on point solutions. We're aiming at lifestyle changes. And number two, we're looking at building a community of people that can support each other, because oftentimes patients who have chronic pain suffer in isolation. Nobody wants to hear the story anymore. Nobody wants to listen because nobody can help. And when we can't help somebody, we somewhat ostracize that person. And we ought not, but that's the story of a lot of folks who suffer with chronic pain.
So when you say that, when Nancy says she's changed her brain to deal with pain differently, what does that mean?
To me?
Well,
or
do you want to tell
yeah.
us how it means, what it means to you,
I think
Nancy?
it's been just an amazing adventure, to be honest with you. I'm going to backtrack just a little, and it's like, what motivated me to go into a pain management program? And I found myself asking myself questions. And the first one was I content with the quality of my life? No. Were opioids helping me? No, maybe, but probably not. And if I did nothing different than I was and had done for many years using opioids, was there going to be any improvement in me? And I knew there wasn't. So I made a very conscious decision, a risky decision, a difficult decision, to open my mind to some new possibilities.
And I understand you're totally free of opioids now.
100%. I never think about them. I don't miss them. I honestly cannot comprehend why for year after year after year I took them.
Well, congratulations to you.
It's a pleasure, and it is so interesting to hear that they actually increased my level of pain over a long term.
Let me ask Dr. Links, I want to find out more about the ER perspective. But first I want to go through a few results that Providence has seen over the last couple of years, because I know Providence has worked really hard on this subject. Emergency department evaluations of the need for opioids versus alternatives has led to a 40% decrease in opioid prescriptions. The use of multimodal pain therapy, we were just talking about, gentle movement, use of non-opioids like acetaminophen, ibuprofen, has improved pain care at hospitals while reducing the amount of opioids required. Chronic pain patients on high-dose opioids have had dose reductions to safer levels with focused work by Providence clinics and Providence Health Plan. Providence retail pharmacists can prescribe and provide counseling on the use of the rescue drug naloxone, you hear about it, called Narcan, and Providence retail pharmacies have drug take-back kiosks to encourage customers to bring back unused opioids. So Dr. Lynn, let's talk about that 40% reduction in opioid prescriptions in your emergency departments. You were part of the process. How did you do that?
Yeah, that's an interesting story. So back in 2011, the Oregon chapter of our national organization called ACEP, the American College of Emergency Physicians. So the Oregon chapter back in 2011 helped draft the one of the very early versions of opioid prescribing guidelines for the emergency department. How to responsibly prescribe opioids. Who should get them, who shouldn't, how many they should get, what are the risk factors for prescribing medications inappropriately. And so for about 5 years, we adopted those across the state and in our department, and we thought we were doing a really good job. And so then it turned out that the state was actually going to start measuring this and start reporting rates of prescriptions for hospitals and actually trying to incentivize providers and hospitals to prescribe fewer. Some of us raised our hand and said, hey, wait a second, we don't really know how many we should be prescribing, number one. So what's the right amount? Like, there's no known correct amount. So how can you incentivize us to prescribe fewer? Maybe we won't prescribe enough. We just didn't know. So then we took a look at it, and what we found is that we had a huge amount of variability in our prescribing, not just across the different emergency departments in the state, but within a given emergency department. So the same providers working in the same department may have a 4 or 5 or 6-fold difference in their prescribing rates, seeing the same patients. And it turns out we weren't unique in this. This was national studies showed the exact same thing. So the interesting part is the way we addressed it was by sharing that data with the actual prescribers and showing them, hey, this is what we're doing. We didn't incentivize it. It wasn't a penalty. You didn't have your license taken away if you reduce. We didn't even tell people to reduce their prescriptions. We simply said, this is what you're doing compared to your peers, and practice changed.
Well, it sounds like you had significant results with a 40% reduction. It's time for us to take a break, but when we come back, we'll talk about the role of Big Pharma in the opioid crisis. We're back in 2 minutes.